Welcome to our fifth and the final meeting for this semester of our seminar series on responsible AI in medicine, hosted by the Bioethics and Law Center at Tel Aviv University. My name is Oren Assman, and it's my honor to moderate today's event. Throughout this series, we have aimed to facilitate meaningful dialogue on the intersection of artificial intelligence, medicine, and bioethics, underscoring our center's mission to foster interprofessional collaboration and education in bioethics. Your participation, as always, and the insights that were shared so far have made this endeavor enriching and thought-provoking. Today, we delve into a pertinent topic, the role of e-mental health services and the pressing need for quality and standards in this evolving field. The advent of artificial intelligence and digital tools has opened new possibilities for mental health care, but also raises profound questions, social, legal, and ethical. And those implications we are going to discuss probably today. And so to guide us through this exploration, we're privileged to have with us today Maureen Abbott, Manager of Programs and Priorities at the Mental Health Commission of Canada. Her work in promoting, and their work actually, in promoting accessibility and diversity and equity and cultural safety in e-mental health services is, I think, inspiring. And I think for responsible and ethical practices in this domain, it might be useful to hear what they're doing and discuss that. Maybe before we begin, I want again to express my gratitude to my friend and colleague, Dr. Amir Tal, who has been organizing this seminar series so well. And I'm very happy again to share with you that together, Amir and I will serve as guest editors for a special theme issue on responsible generative AI in mental health. It will be published with the Journal of Medical Internet Research Mental Health. So if you have a paper you're working on or you're considering writing, we invite you to reach out to us for more information, which will soon be available online, I guess, within a week or two. So now it's my pleasure to introduce today's speaker, Maureen Abbott. She will share with us the Mental Health Commission of Canada's journey towards improving mental health services, the development of their new assessment framework, and their ongoing efforts in creating an inclusive and ethical e-mental health strategy for Canada. Maureen, the floor is yours.
Thank you so much, Oren, and thank you so much to the University of Tel Aviv. Amir and yourself have been so helpful, and it's been so great connecting with you on this process. So thank you so much for the opportunity to connect with other colleagues as well abroad. So I'm Maureen Abbott. I'm a manager at the Mental Health Commission of Canada on the Access to Quality Mental Health Services team. And the Mental Health Commission has a unique mandate from the Government of Canada to support federal, provincial, and territorial governments, as well as organizations to incorporate best evidence into public policy through research and knowledge translation. And we collaborate with national and international stakeholders in often everything that we do. And I manage our e-mental health files specifically. So through my team, we try to focus less on that technology piece and more around how mental health technology has the potential to improve access to mental health services and quality mental health services, and even reducing backlog in the system as well. And you can feel free to share the slides if you like as well. And we can go right to the second slide on contents. Thank you. So for today's presentation, we're going to start off by discussing the case for e-mental health and the need for quality e-mental health products. And then I'm going to discuss 4 of our key projects at the Commission. That includes our app assessment framework, our e-modules, our e-mental health strategy for Canada, and a discussion around artificial intelligence for mental health. I know that you're all well versed in AI, but wanted to bring some key points for the mental health area specifically. And then we'll finish off with lessons learned. And I'll make sure to be within 45 minutes for the entire presentation, and then make sure that we have time for questions. But I do want to let you know that this will be a bit more interactive. So we're going to use the chat for a few questions. And also I will have a number of QR codes that will come up on the screen. So feel free to get your QR code reader ready. And in terms of the time, yes, we'll do 45 minutes and then make sure that we have time at the end for questions. Great. So in terms of the topic of mental health in general, it's reported that 1 in 5 people in Canada experience a mental health illness and need mental health care. And the World Health Organization worldwide estimates that 450 million people suffer from a mental health illness and need mental health care. So, take a look around your physical or your virtual room, as well as your family and friends, and consider the 1 in 5 people around us, if not us, that are experiencing a mental illness and need care. And that is 20% of Canada's population. However, I think it's important to note that on top of those statistics, it is the 1 in 5 reported. So that's not counting the number of people that experience a mental illness that do not seek help. And again, on top of those stats, it really isn't just the 1 in 5 people that are affected by a mental illness. Really, mental health and mental illness affects everyone. Since if you've ever cared for or encountered a family member or friend that has a mental illness, that very much affects you too. And COVID has only intensified the pressures on many people in Canada. So before the pandemic, about 2% reported moderately severe or severe symptoms of depression. And then today that number has skyrocketed to 14%, or 1 in 7 people. Next slide, please. And there's a huge economic cost to support those experiencing mental illness and needing support, even more so than diabetes and heart disease. And it's costly as well. And it's also connected with physical health services, since our emergency departments in Canada, assuming it's very similar in other countries as well, where people may go in crisis, are extremely crowded. How many people are also having trouble getting treatment because they don't have a family doctor? My parents are a great example. They do not have a family doctor, unfortunately, and they're aging. So what if there was a way to think about things a bit differently and alleviate the pressure on our physical and our mental health care system by thinking creatively about access? So not everyone needs the same type of level of care. Some people might need higher intensity services and in-person visits, but some might be able to manage their mental health through mental health apps or online services, or a single session, or an online chat room or peer support, for example, or other low intensity services. So why are we trying to fit everyone around the same access points? Next slide, please. As another access point, e-mental health can be used on its own or together with in-person care. And we never try to claim that e-mental health is for everyone, but having another access point with e-mental health can reduce the pressure on different points in the system. And there was a project that we just finalized at the Mental Health Commission using a Step Care 2.0 model. I'm sure Step Care rings a bell in many countries. And what we were doing is using this in provinces and territories, and it also incorporates an e-mental health model into the picture. And it's the idea that not everyone requires that same level of care, but care can be stepped up or down based on need. And that work just concluded in the Northwest Territories with a 79% decrease in wait times for counseling services in the region. And I'll also put the link to that report into the chat as well in case people are interested. So there are many different types of e-mental health services. E-mental health can be used together with face-to-face services or on their own for those who want to maintain their own wellness and mental health. And then there's also many definitions of e-mental health. But at the Commission, we use a broad definition. So it's not just apps or AI for us, but also text reminders for appointments and telehealth. E-mental health can be used for mild to moderate issues, but over time, we're seeing that e-mental health is being used for more severe and persistent issues as well, such as apps for suicidal ideation. And it's also being used to treat PTSD for more severe trauma in virtual environments as well, called 360 environments. And the Mental Health Commission of Canada has been in the space of e-mental health since about 2014. And since then, we've been developing many e-mental health resources, which is available on our website. So at the end of the presentation, I'll also send the link to you on our website. Next slide, please. Great, so now we're going to do a bit of an interactive session. So I'd love for you to put your answer into the chat. So for this question, we're going to do some myths or facts. And the question is, e-mental health services are not as effective as in-person services. Can you put in the chat whether you think that is a myth or a fact? Don't be shy. So I'm getting lots of myths. Great, and next slide, please. And that is correct, it is a myth. So when implemented properly, e-mental health services are just as effective as in-person services, or on their own or with a practitioner. And many practitioners we know use e-mental health services actually during their practice or between sessions. And during the pandemic, in many cases, e-mental health was the only option for receiving services. So it's definitely become a coming of age for e-mental health. And I think it's important to stress here that like in-person services, e-mental health services need to be implemented properly. And we're working on that in order to get people the right resources they need. Next slide, please. So the next question, myth or fact, people don't want to use e-mental health services. So take a few minutes to put that into the chat. I see a few familiar names here. Welcome, Beto. It's great to have you online. Great, and next slide, please. So yes, so this is a myth. And an organization that we're working with in the UK, Orca, has seen a 6,500% increase in people using apps in the UK specifically. Here in Canada, Wellness Together Canada, which is the online portal for e-mental health services, has been reporting an increase in people wanting to use lower intensity mental health services like apps, especially. Kids Help Phone is a service in Canada that has seen 137% increase overall during the pandemic, with 59% increase for texting services in particular. And of course, some people would still prefer to use in-person services, which is completely valid. But we want to be clear that e-mental health can be a great option, as well as it's implemented, as long as it's implemented correctly. Next slide. Great, so the next one, how many people feel less stigmatized with e-mental health services? A myth or a fact? Great, thanks for responding in the chat, everyone.
Do you see, because I get some of the responses.
Great, and next slide, please.
Do you see the responses of people who are not us?
I can see them in the chat.
Okay, so I guess
yeah.
I can see all that, okay.
Yeah, exactly, yeah. So this one is a fact. We've heard from our stakeholders that people don't always feel comfortable walking into an in-person space, and people are looking for a safe space and have anonymity as well and not be judged. Peer support groups online have also increased in popularity. We've noticed that youth especially really appreciate safe spaces and anonymity of e-mental health services. Many are already online anyway and appreciate having mental health services online. For example, Kids Help Phone found that Indigenous youth were using their Facebook Messenger service on a day-to-day basis for communication. So what they decided to do was introduce a messaging services for mental health right in Facebook Messenger. So just kind of fit in with what people are already using and being able to incorporate a mental health solution that way. One other item is we have many new Canadians coming in, as I'm sure, you know, in many of your countries it's similar. And a lot of people face a lot of stigma in different countries as well relating to e-mental health. So whenever they're coming in and needing e-mental health services, it can be less intimidating for them to not have to walk into an in-person services. And sometimes that e-mental health services can be that space that people can feel more comfortable in. Next slide. Accessing services from a remote area can be a barrier for e-mental health services. And this is the last one, myth or fact? Thank you for your responses. Great, and next slide, please. It is a fact. We do recognize that remote access is a barrier for accessing services. So we certainly encourage you to continue to campaign your governments and policymakers around getting access to services, because from what I hear, I think this is a worldwide issue. I was in Brussels a few weeks back at the Computer Data and Privacy Conference, and this definitely came up as an issue for access. So certainly continue to campaign for that access. And this affects certain communities especially. So in Canada, Indigenous communities are very much affected. However, we've also heard from Indigenous Services Canada that many apps are better for remote areas. So for example, apps that have lower bandwidth are a little bit easier than other e-mental health services like telehealth, for example. And there's also ways that we would encourage people to try to get around that remote access by providing the capacity to print off items and use items that don't require as much bandwidth, especially for those areas. Next slide. And I think it's always important to be able to hear people's stories, so directly from the people that are experiencing these issues. And the link through the QR code is a story that is now available to the public in a short video. It's about a young woman, and the first time she accessed online services was through a messaging service by a Kids Help Phone in Canada. And she couldn't believe that she was able to get service immediately. And she was able to then support her in telling her family that she was struggling and needed more help. And she also used apps and other online services and activities to be able to ground herself and prepare for entering the outside world. So she could go and write a message on the board and connect with people. And the first time she realized that she wasn't alone. So please, feel free to take a look at that video to just hear about how some people are using e-mental health and how it's, saving their lives from their words as well. Next slide. Great. So one of the key projects, I'm going to start discussing some of our key projects now at the Mental Health Commission. And one of our key projects we've been working on over the last few years, especially on e-mental health, has been creating standards for mental health apps in Canada. Because we know that people are very interested in using apps for mental health. I think we already established that through our myths or facts. And we know that people are keen to choose digital solutions overall, especially youth, and that there are a large number of mental health apps out there. And there was a survey that was recently done with Canada Health Info in 2021, and they asked Canadians these questions, and 73% of people said that e-mental health has helped them deal with a moment of crisis or distress that would have resulted in physical harm or suicide. And 63% said that they wouldn't have sought care if virtual options are not available. So the case for virtual options, and especially mental health apps, is very strong in Canada and abroad, but there is a challenge that I want to address now and throughout this presentation, and that is around the quality of these products. Because unfortunately, we do not know if mental health apps in Canada are safe, quality, and effective. And there was limited standardization that existed out there. And we think there are some great apps that exist, but we also know there's been instances where the wrong crisis line number has been shared with apps, or that people's data has been shared with different telecommuting marketing companies. And we desperately need to know a way to know the quality and be able to communicate this to those living in Canada. Next slide, please. So another quick question for you: out of 700 mindfulness apps reviewed, how many out of the 700 would you estimate are based on sound evidence? Feel free to put that into the chat. 425, 600, 104, or 23. Great, next slide, please. This is a really smart group, and yes, you're right, it is 23. Unfortunately, it's 23 out of 700. In a review of the iTunes store, only 23 out of 700 mindfulness apps provided mindfulness training or education, and only one was supported by empirical evidence. So it's really unfortunate right now that anyone can access mental health apps in Canada and abroad for most places, and we don't know if these apps are safe, quality, or effective. And the number of stars that an app gets in the App Store doesn't correlate to its quality, safety, or effectiveness. And there have been some cases where mental health apps have made errors, and that has also been noted. So we desperately needed a way to be able to figure out the standardization for these apps. Next slide, please. So with funding from Health Canada, we started this journey about 3 years ago to develop standards for mental health apps in Canada. And throughout this process, we have been working with ORCA, which is the Organization for the Review of Care and Health Applications. And ORCA is working with over 30 jurisdictions around the world to set up similar standards for mental health and health apps. And ORCA has a base set of standards that already takes a systems approach. So it draws in all of the relevant information. And then with each jurisdiction, including Canada, we needed that feedback from our stakeholders in order to make the standards relevant for the Canadian population specifically. So throughout this process, we engaged about 200 of our stakeholders, and that included those with lived and living experience, providers, app developers, researchers, and health executives. And we also had somebody with lived experience right in our core development team. And that made a huge difference for us in terms of the direction that we were going. And I would highly recommend that as well if anyone is thinking about undertaking a similar journey. And we did have a lot of back and forth throughout this journey with our stakeholders, so many different drafts that we worked on. We also had a public review, which was really important to us. And this allowed us to have the standards open to the public for 4 weeks and gained feedback. We did receive a lot of feedback around diversity and inclusion, specific to the content, and also empowering the end user to have ownership of the data. And we asked the question in the public review as well: overall, do you think the standards and criteria fulfill your expectations of how mental health apps should be assessed in Canada? And 88% did say yes, that they did feel that way. So that was a great indicator to us that we were on the right track. Next slide, please. So this is hot off the press. I'm so thrilled to be able to share this with you, but we do now have the app assessment framework publicly available as of June 20th on our website. So we have a specific kind of a smaller website dedicated to the app assessment framework. excuse me, you can access it via this QR code or via our e-mental health page that I'll also share at the end. Next slide, please. In terms of the breakdown of the assessment framework, so it begins with a glossary of terms followed by an app overview. And then the assessment framework has 7 different areas of focus that we're calling standards. And then within each of those standards is criteria that the app needs to meet. And there are 450 criteria total, actually 450 plus within those 7 standards. So it's not a quick read, but it is an important one. And all of the standards draw from relevant technical standards as well, and they do incorporate a scientific approach and a rigorous approach based on the level of the app. So apps are assessed based on different tiers. For example, a wellness app would cover a different intensity of service than an app that deals with suicidal ideation, and they would be assessed differently. In addition to the first 5 standards, with our Canadian stakeholders, we really had to come home on our values and what our values are for apps assessed in Canada. This is actually a bit of a theme that I'm hearing recently with artificial intelligence and e-mental health solutions, is really thinking about, you know, as a community, as a country, what do you feel are your key values? And that's really what we undertook in Canada. And one area that really stood out for us was not necessarily captured in other frameworks in other countries, but it was around cultural safety, social responsibility, and equity. And Canada is very multicultural and diverse, and we also have an Indigenous population. And it's not surprising that this content came out during this process. So we decided to make it its own 2 standards. So this includes content on key topics such as Indigenous data security and privacy, gender equity, representation from the BIPOC community, that is Black, Indigenous, and other people of color, and having that representation in app content and visuals, and usability and accessibility, and also lived experience involvement in the app development. Next slide, please. So these are some examples of the criteria that are shared in the cultural safety section of our app work. Some of the specific questions that may be asked are, is the text on the app readable at a grade 5 level or below? Is the language gender neutral? Has a process been designed and put in place that allows Indigenous users to easily access and understand and exercise their own data protection rights? And these items are all very important to us, and our stakeholders identify these as areas that we do need and to include in an app assessment framework for Canada. Next slide. So in terms of accreditation, it's our goal to create a national mental health app library for the Canadian population so that all those living in Canada can access safe, quality, and effective mental health apps easily, and they know where to go to be able to find those. We'd also like to include a login for providers so that they have the option of prescribing safe apps in their practice. But we do need additional investment for this work, so we haven't been able to do that yet. It's a bit on hold, and we decided to take another approach. Thank you. You're quick, Maureen. So to get to that point, we do hope to have a voluntary accreditation process for mental health apps in Canada in the future. We just don't have that yet. So other countries, you know, that I'm sure that you know of, like Australia, for example, they do have a process in place for all of their e-mental health products where they do go through this accreditation process, and then they do have them available to the public. That would certainly be a goal for us. We're just a little ways away from that and still working towards that. But many provinces and territories in Canada, so, you know, we're really divided up into different provinces and territories here, and many of them have come to us and saying that they would like to build their own mental health app library with apps that have been assessed on this framework. I'm not sure how familiar you are with how it works for the funding for mental health in Canada, but the provinces and territories receive transfer payments from the federal government, and then they have a bit more autonomy to do what they like with their funding for mental health services. And I should also mention that we do not have funded mental health services in Canada. So those that have insurance through their work will probably receive some amount of funding for mental health in Canada. So they might receive an X number of sessions, but we do not have, excuse me, funded federal mental health care in Canada, unfortunately. And I think that is a big piece of the puzzle. And that's another reason why I think e-mental health services are so important. So just back to how the provinces and territories would like to use mental health app libraries. So it's a way for them to be able to tell which apps are safe and effective for their region, and then be able to share this with their residents. So what we've done, we have started working with one province already, and there's many that are very interested. And we've turned our assessment framework into an online digital review engine for these provinces. And so we've been taking a bit of a more regional approach. And what that does is, so we have everything online, and then the provinces are able to kind of select which apps would go through that assessment. And instead of the apps going through the 450 criteria to PDF document, it's able to be done online for them. So it's a lot more efficient in that way. So in short, there's no national accreditation yet in Canada. We're hopeful that it will be a reality someday. And for now, we're working with individual provinces and organizations as well. Next slide. And the MHCC is also included in a case study, which will form part of a retrospective paper on government frameworks in digital mental health, as well as a follow-up to the Global Governance Toolkit for Digital Mental Health. And that's published in the World Economic Forum document here in collaboration with Deloitte. So feel free to check this out. It's a really great snapshot of not only apps, but a lot of the work that we're doing in Canada as well around e-mental health at the Commission. The next slide, please. And I just want to do a time check, Oren. I know we started a bit late. Would you like me to finish in about 10 minutes, or do I have a little bit extra for that?
I think you can take 15 minutes or so, and it'll leave us enough time to discuss.
Perfect, great, thank you so much. Great, so another area that is of relevance that we work on our team is e-mental health implementation. Because like in-person services, e-mental health services only work well when they're implemented properly. And the e-mental health implementation learning modules developed from the Mental Health Commission of Canada toolkit for e-mental health implementation, so that's a separate document. It was developed into a course, basically. So the course was developed in collaboration with the Center for Addictions and Mental Health. And the online modules are free, they're self-directed and designed to give mental health providers, managers, leaders, and students the knowledge and skills they need to be able to integrate e-mental health into their daily practice and support effective person-centered e-mental health service delivery. So these are the 4 modules that map onto our toolkit. Please feel free to go ahead and access them to see if they would be helpful for you as well in your practice. Next slide. And this is a visual as well of some of the key components in the course. The course is available in English and French, so we're a bilingual country. And there's over 1,000 people now accessing the course, and over 100 people who have completed the entire course. And it's accredited by the Canadian College of Health Leaders as well. And some of the new pieces that we are interested in incorporating into a case study, so we did do a bit of a review to see, what are some areas that people would like incorporated in. And people are asking for kind of more context and content around the BIPOC community. And we'd also like to enhance our section on AI as well. So we do have a bit of a section on AI in this course, but we are thinking of perhaps even making it its own module. Next slide. So this slide looks sort of similar to the previous, but it is a separate project. Actually, how we came about doing these slides for this one particular, this is coming to our e-mental health strategy work. We did have a national event discussing the e-mental health strategy for Canada, and we had somebody developing these in real time. So an illustrator who was actually developing them as people were speaking. So it was a really fun process to be able to see. And now, of course, we have these great drawings as well. But the MHCC has been mandated with developing Canada's first e-mental health strategy by 2024. And really with the advancement of technology, there's been a call from stakeholders and governments, communities to see a strategic focus on the future of e-mental health. And we're seeing this in other jurisdictions as well. So it's not only Canada. I know, there is a call for this in the EU as well, and they're thinking about developing a strategy in the European Union. And we have 2 years to complete this work. So we're nearing the end actually of year 2 of this work. So we'll be going live in the spring of 2024 around the strategy. We started by developing an environmental scan and a literature review and stakeholder map to make sure that the strategy was grounded in sound research and success from other countries that have done this. Australia, another example, has a really great robust strategy as well that has made a lot of policy decisions as well in their country. And we have an advisory committee that we have implemented for this work. And these experts include policymakers, practitioners, and health leaders, and also those with lived experience with mental health issues. And these members have been meeting regularly, and with them, we have developed some key principles and themes for the strategy. Next slide, please. Great, and one of the main issues that we actually started it with, even before I get into the key principles, was around if the 2012 mental health strategy for Canada should be attached to the e-mental health strategy, or if it should be included in the 2012 strategy, the mental health strategy for Canada, or if it should be its own standalone document. So what we decided with our stakeholders is to make it its own standalone document, since the 2012 mental health strategy was built, way back in 2012, but we still wanted to connect it to that 2012 mental health strategy for Canada. And that's what you see on the slide. Next slide, please. Some of the important issues that have been embedded into the strategy include the idea, so embedding idea, which is inclusion, diversity, equity, and accessibility, and ensuring that these principles are in all e-mental health developed resources and delivery. And it can be challenging to see specific viewpoints of others and how a simple choice can create unforeseen, unintended barriers for others as well. So the most important consideration here is ensuring that those with lived experience and equity-seeking groups are engaged early, engaged often, and also have a meaningful role in shaping both policy and solutions as well. And there'll also be recommendations for issues relating to the mental health workforce. And this is an ongoing issue that I hear for e-mental health, for AI specifically as well, is, well, really the mental health workforce is one of the workplace sectors which was deeply affected by the pandemic. And we must be cognizant of how we support this workforce through the transition to e-mental health, with specific attention to limiting more burnout for the e-mental health workforce as well. So this section will include training and ongoing support for the e-mental health workforce, new and defined roles, and also technology leads in organizations. So making sure you have that dedicated e-mental health resource there. And then lastly, navigation is also a key topic. So ensuring that people know where to go to find quality e-mental health resources, and also having quality standards and rigor to ensure that e-mental health solutions are safe, quality, and effective. Next slide. Thank you. So I'm wrapping up our projects now with a discussion around artificial intelligence and mental health. And I know for a lot of the people here, this might be your bread and butter for AI. So I know that it will be a great discussion and great questions after around this. But for AI in Canada, it's already being used in our everyday lives for items like banking, preferences for shopping, ads and social media. And many of us also have our virtual assistant device in our home, who I won't name, or else you're going to hear that person go off or that AI device go off, but you know who I'm talking about. So it's really only natural that AI is happening for mental health services as well. And the Commission identified a need to explore the use of AI and machine learning in the prevention, early intervention and diagnosis of treatment of mental health and addictions. And that we've been hearing from our stakeholders that the use of AI in mental health is increasing in general. It's being used in speech recognition to pick up the cadence in a person's voice and help diagnose manic episodes and depression. It's used in chatbots for machine-led learning. It's also used in social media to identify trends for suicidal ideation. AI also allows us to scan for words and phrases as well to be able to pick that up. And also in mental health apps. So it's part of our framework as well for mental health apps. And then organizations like Kids Help Phone are using AI to detect words in chats and text messaging that are then used to be able to triage clients if they're having suicidal thoughts as well. So we knew that these processes existed, but we wanted to learn more about the effectiveness and the safety of AI. So that brought us to developing some reports with an organization in Canada, CADIT, the Canadian Agency for Drug and Technology in Health. And you'll see a link to the short report on the left-hand side. We do also have the long reports available on our website for anyone that would like to read through those. We also have national events from time to time, about every year. And this last February, we had a national event on artificial intelligence in mental health, where we were really talking about key topics in AI and mental health in Canada. Also on the right, you'll see a QR link to a podcast that I just recently did with Canada Health InfoWay that could be of interest. And all of these items help to inform our next steps in e-mental health in general at the Mental Health Commission, and they also help us to inform our stakeholders as well. Next slide. So I'll tell you a bit now about some of the gaps that we're seeing for AI and mental health. The first is research on using AI for preventing mental health problems is lacking, as are guidelines for using AI in mental health care. There's also a lack of research in accessing AI in specific groups, such as older adults, immigrants, refugees, ethnocultural and racialized populations, First Nations, Inuit and Métis people, and members of the LGBTQ2S+ communities. And also AI technologies are still in early stages of development and testing. So without more research and identifying how to use AI more effectively for mental health services, it's still a bit unclear. And the safety as well for using AI in mental health care is also unknown. I'm sure that you've seen a number of cases in the media as well about AI, where there actually has been some tragic cases of AI instructing people and being programmed in the wrong way as well, and instructing them in ways that have been fatal for a lot of people. So it's something that we do keep top of mind. And then with also many AI applications still in research and development, their clinical use for mental health care is also limited. So available clinical uses right now include diagnosis and prevention. So that's detecting the risk and connecting users to appropriate supports, as well as the treatment. So using conversational agents is one way to deliver cognitive behavioral therapy, for example. Next slide. So this could all be a presentation on its own. Each of these projects could be a presentation on its own. So I'm just really giving a snapshot here of AI and mental health. But I did want to share a few policy considerations, recommendations, and future directions, and happy to continue this conversation. But policy considerations include the feasibility of adding AI to the workload of clinicians. So I've already mentioned this notion of the workforce that is, on the verge of burnout if they're not already burnt out. So considering that is, a huge factor. Also, whether healthcare providers focus only on patient data while overlooking an individual's lived experience. It's something to also keep in the back of your mind and note as well. For recommendations, clinician and client perspectives are really important to be incorporated right from the beginning. Also, culturally sensitive algorithms need to be created as well. And for the future, I would love to chat more with you all around this, but from what we see is that social media will continue to play a big role in the prevention, especially detecting risk, connecting users to support, also for triage purposes as well, and also, for example, analyzing social media posts. I'm also seeing that there has been a lot of interest from governments, especially in Canada, around using AI in healthcare, because I think people see a business case for the use of AI. People are interested in using AI for triage and emergency departments, etc. So we have been getting a lot of interest around that as well. And next slide, please. I think it's important for us as an organization that all of our work is inclusive of those with people with lived experience accessing mental health services and using mental health apps. And then with that, we also need to create safe, brave, and virtual spaces for these people to feel comfortable enough to be able to share. Because often, whenever you're working on projects like this and developing, we have people with lived experience in the same room as CEOs. So it's really important to be able to ask people, what would you feel comfortable sharing, and what do you need in order to feel comfortable in a virtual space like this? And with that, we also need to train our entire team to accept people with lived experience as expert advice. We also include a range of stakeholders in our projects, which is really key, I think, to the success of our projects. So we include providers, app developers, policy and research specialists, health executives, those with lived experience. And then also, it's so important to be able to connect with other jurisdictions around the world. We've connected with New Zealand, Australia, Brazil recently, Beto, Israel, you all, Ireland, Denmark, to really learn about what are the lessons learned as they're completing a similar process. Next slide. So these are the outcomes that I hope that you took away from the presentation today. I hope we now have a shared understanding of the opportunity for e-mental health, a shared understanding of the need for the quality e-mental health projects and really products, and really the risk associated if we do not do that, because the time is really now to be able to act. There are so many missteps happening that we do need standardization, and we do need people to come together. And we also need for these products not to just sit on a shelf, but to be able to be implemented, to be able to help those to be able to make an informed decision on accessing safe, quality, and effective mental health products. Also, you should now have a knowledge of our Mental Health Commission of Canada e-mental health resources and products and where to find them, and lessons learned around key components of quality e-mental health products. Next slide. And this is our wonderful e-mental health team at the Commission. We certainly couldn't do any of this work without this wonderful team. It is a fairly small team that we work with, but it's a very small but mighty team. So I wanted to thank everyone who works on the team with me. Next slide. So as promised, this is our Mental Health Commission of Canada e-mental health webpage that you can navigate to, and you can access all of these resources that I mentioned in the presentation here. And thank you so much, everyone. It's been a pleasure speaking with you today, and I'm looking forward to the discussion.
Thank you very much, Maureen. So we ask that anyone who is possible to open their camera, you're welcome to do so and join us in this discussion. And we have people from various backgrounds, both medical, legal, philosophy, engineering, and other fields. And let's just open it up for questions or thoughts. Please, you could either raise your hand or just barge in. Yeah, Yoel, please.
Yeah, I have few mental problems really now, and I know how does it work. I call you, it's a face-to-face. It's the same the physician or psychologist. I mean, working in a mental institute, it was great not to come to the hospital and do it from home. That's one of my mental problems.
Yes, and what country are you in?
It's Israel. In
Israel, yeah. And actually, Lauren and Amir might be better to be able to answer it in Israel, but I hope there would be some e-mental health resources available for you all. I think if there's a place where, is there a place available where you could navigate in order to figure out what is available both in person and e-mental health?
This, this is a very good topic, Yoel, that you're bringing up. So
I want to see the system. I mean, how does it work? Or this, what is a spectrum of patient? Is someone who is in severe schizophrenic attack or something like this? Does it work, or it's only just a little depression here and there that just, you know, the phone help system can help you? We have this Iran or whatever it is.
Helpline. He's
Yeah.
talking about helpline.
Yeah, I mean, I think, you know, you're bringing up the point of navigation. Like, you need to know where to be able to go to be able to find these resources as well. So it needs to be clear to the public. So, you know, if none of us here know where you could go right now to be able to access mental health resources or in-person resources, that's also an issue as well. So, I mean, I really do hope that there is crisis line numbers available in Israel, and there is, you know, if it's a website or a place where people can go to be able to find out, you know, where they can seek support as well, which is so important. So,
Yeah,
I don't.
I will probably just add one thing here, specifically about Israel. So there are different questions here, because you referred to a large variety of options. Some are private projects, many are EFU would be adopted in one way or another by the HMOs at some point, or hospitals. It's going to be a process, but currently, I think if I try to take Yoel's question seriously, I think he's alluding to the question of accessibility, and also how adaptive is the system to different conditions. Obviously, you cannot treat all patients in the same manner. It's just like you cannot take a person in a severe heart attack to only just like a primary health center with no urgent, equipment to help him with, or it might be better than nothing, but maybe not. So in this regard, obviously it cannot offer solutions to everything in one system at this point in time. I could say though, that there's also the matter of taking time for the system to adapt to these new things. So for instance, if we have patients coming to a clinical, like to a health clinic once a month, for a very short visit, it does bear the question, is it very useful for them to physically come there, or could it be done remotely? And in some cases, it may not be because lack of ability to do it, but maybe willingness of the system to try to adapt to allowing people to enjoy the benefits of what we can already do today and keep doing things the way we did before. In this way, I think both patients and their healthcare providers are paying a price for our struggling to adapt to the new possible reality that we could have. Just a thought, though.
Yes, and I did also put into the chat a link to the Step Care 2.0 report that I did want to share with everyone, because, you know, like you said, I think it's so important to have different levels of care and different access points depending on the service that you need. And this process also had great results in the Northwest Territories, you know, a huge reduction of wait times as well. And a lot of that was around, you know, navigation, access, where to find the services that you need at that time. So that could also be helpful for people if you are looking to set up a system as well.
Yeah, more questions, please.
Hi, can I ask a question, please?
Sure.
Hi, my name is Tamar, and I come from a legal background, so excuse my question if they're a little bit too legal. I was wondering, just as a preliminary question, did I get it right that the standardization? By the way, it's an amazing achievement, I think, to have a standardization for some sort of clinical validity. I think many health applications would be happy to have such a system. But did I get it right that is it voluntarily? Do the companies self-declare, check themselves through the engine, and then, you know, either you can supervise them or not, but this is what they claim?
Actually, there isn't any process at the moment for voluntary accreditation. That is what we would prefer. So if we do have a system of national accreditation and we do get to that point where we do, require extra funding in order to implement a system for a national standards in Canada, if we are able to get to that point, then yes, we would have a voluntary accreditation process where app developers can go and to be able to have their app assessed against the standards. At this time, we're working with provinces and territories who would like to do that. So the process right now is for the provinces and territories to be able to select which apps they would like to go through that process. So it's not set up for national accreditation yet, but hopefully in the future, we'll be able to do that.
And the ones that are chosen are part of the healthcare in the same province or territory, or is it again some commercial, more, something that the person can choose to buy?
Yeah, great question. It's really however the province wants to set it up. So, we're working with one province at the moment that is, right in that midst of those app selection. And we really encourage them to think about, what is being used in their region? What are the apps being used in their province? And thinking about their province specifically. Like, for example, do you have a large Indigenous population? If so, maybe you want to select an Indigenous app that would work with that population and people. Do you have a large children and youth mental health population? Thinking about kind of a broad range of different apps that they can select in order to, get to a range of populations, also a range in severities of issues as well. So perhaps a mix of wellness apps, a mix of kind of more mid-range apps and those that deal with suicidal ideation, so that you're really sort of getting at all the different population groups in your region.
Great. And do you have a sense or feeling in which field of mental health with the apps and this validation system would be, best fitted, or are they like I would assume children and youth are my immediate suspects, but perhaps there are others.
There's actually a huge range of different types of acts. So there is lots for children and youth. I know, when I was chatting with Beto in Brazil, he was also telling me kind of there's a big focus on children and youth, which I see as well in Canada. There's one in particular that I'm thinking of. It's a really great app actually on Indigenous youth, ages 8 to 13. And it's actually an app that deals with suicidal ideation with Indigenous youth. So it's a lot of people, very specific, and a lot of people feel that apps are often for lower intensity services, but really I do want to stress that there is a lot of apps and e-mental health services out there now for more higher intensity services like suicidal ideation. So it's sort of a misperception, that it's just for kind of more lower intensity, but a huge range, lots of different populations. I think children and youth is a big one for sure. Then you also get into thoughts of, is the child able to use the app on their own, or would they have to have it with support depending on the topic as well? So yeah, lots of key questions there depending on the population served.
And my last question, just not to take from the other people in the audience, you were talking about involving people with experience, and this is really interesting. Is it something that you put, I can understand how you put it in standardization, but do you also require it from the companies which develop the apps? Do they need to show some sort of, involving it in the process or in the implementation of the app?
Yeah, what a great question. And I think it's really interesting because whenever we started on this journey, we did an environmental scan, literature review, and stakeholder map. And one thing that really came out in that scan was that these apps were not being developed at all with those with lived experience. The end user was not even a part of it, not only in the development, but even in the testing. People weren't even testing the apps with those with lived experience, which is surprising, right? Because you want to make sure that your product is relevant for your end user. So that was something that we really wanted to incorporate into our framework. So we do have criteria in there, asking that the app is developed with the end user, and also in the testing as well. And that's kind of one of the pieces of the 450 criteria as well.
Thank you so much. It was fascinating.
Yes, thank you.
Thank you. Yeah. More people, please. I'm thinking about the concept, Amira, before you say that. So really, you know, you're talking about the disability-related standard of nothing about us without us. I think about the empowering element of including people, stakeholders, when you're planning something. So I get why sometimes including people in the training of new professionals is maybe sometimes a challenge, and you do it, but maybe you don't do it enough. But when you plan a system that could provide the services, and you tell people, look, what's your dream support? What would be the things you wanted to hear but didn't hear, and so on. I think it could have almost a therapeutic effect to it, just the process itself, not just the end product. And in itself, it's a wonderful experience. And I think from a perspective of organizations and corporates, there is this concept of corporate giving back to society. So in a way, it's not just about good business plan and ethics. It's also about contributing to the society that will eventually bring you the money. So just a thought I had in mind. I mean,
it's so true. And you know, it's only recently, really in recent years, that people that are the end users and those with, you know, lived and living experience have been incorporated into these discussions. And unfortunately, you know, in the past, and even in some places, you know, today, there's a lot of people that don't see that advice, you know, as expert advice as well. So they're more, you know, going only to scientific ways and research ways, but, you know, thinking about it from a holistic view, incorporating everyone into the discussion is so important. But I think, you know, if you are all thinking about incorporating those with lived experience into the discussion, you also have to know that you have to create that safe space for them to be able to share so that they do feel comfortable sharing. And, you know, like you said, Oren, making sure that they feel empowered to be able to, you know, share not only for your project, but then, you know, as they seek medical and mental health advice afterwards as well.
Right. I think that in that sense, Dr. Patricia Deegan, which is also promoting technology, is doing a great job in obviously including persons with lived experience in the process. Yeah, so I was wondering, like in the macro level, we know that one of the promises of e-mental health is to promote measurement-based care, value-based care, etc. To what extent do you feel that the great work that you are doing, have been indeed promoting, you know, in the field? Like, are people more using more, you know, measurement? Like, do they use more measurement and outcomes to see to what extent the services that they're providing is indeed efficient?
Yeah, that is something that we certainly encourage everyone to incorporate into their products. So even in our e-mental health toolkit and our e-modules, which I shared the link, that is a very key area, is ensuring that you have metrics for success, and then also that they're measurable as well. And that is something that we also do with all of our products. So we have key performance indicators that we have incorporated in, as well as ways to be able to both kind of get qualitative and quantitative information around the products as well at the end. And then every year, what we do is we look at that information, and that designs our work plan almost for the next year, as we think about, you know, ways to be able to improve and what people are looking for in the products. And if also, you know, they're successful as well, right? Because, you know, even, you know, in the app framework specifically, we have a large section on clinical effectiveness. So we want to make sure, you know, that the products themselves are also successful and that people are using them and that it's working for people as well.
Can I ask a question?
Sure.
Hi, my name is Shlomit, and my question is actually, it's more kind of like I'm thinking loud, and I wonder maybe you have more insights. I too heard, even before your really great talk and presentation, that mental health is something that people prefer to get, you know, online and maybe in virtual senses. So this is how I knew it's not a myth that people preferred it. I got the right answer. But my question is, and you know, part I think of the need of people, like patients in general and mental health patients in particular, is to deal with their loneliness. And I was wondering how does this go together? It's just, you know, a question. You probably don't have good answer for that, because it should be something that we should study more carefully. But do you have any thoughts about this?
Yeah, that's a great question. I think, you know, just to your first point too, I think really what we think is best is being able to provide access for mental health services however people would like. So being able to choose when, where, or how that would work for you is what we would promote, really. So whether that's e-mental health or in person, whatever works best for you is how we're trying to provide access. And it doesn't matter whether it's e-mental health or in person for us, just that, you know, the bottom line is that people do get access in some way. So I think, you know, like with loneliness, I mean, COVID-19 is a perfect example, right, of people being isolated and not be able to, you know, to interact with people. And if people are looking for that face-to-face, I don't think there's ever really, you know, a way to be able to replicate that online if you really do need that face-to-face connection. So I really do think, you know, there is a place for that, like to be able to like be in the same space as someone and to be able to interact that way. I know, you know, some people do naturally tend towards different online services for loneliness even. So, you know, in the story that I posted, there was a young woman that was saying that she really found a community in the peer support group. So, you know, be able to access that at, say, like it's midnight and everything is closed and you don't have access to an in-person service, but you can log into your app where you have access to an online community. And it makes you feel as though you're not alone and you're not the only one experiencing a mental health issue. So you kind of have that peer-to-peer support, or you're able to access, you know, a physician as well and services that way. So yeah, I think, you know, there's advantages to both as well. And I think, you know, the main point is really just being able to advocate for that access piece. So whichever way people choose, whether it's in person or online, to be able to access services, but having those options for people.
Okay, thank you.
You're welcome.
Thank you. More thoughts? Ella, your smile speaks volumes. Is there something you want to share with us?
I wonder if in a place with a shortage of or a low level of mental health, the mental health can overcome this shortage, or maybe it increases the shortage because people professionals will start with the so it's some kind of a problem.
I think it's a different way to access services. So if, for example, everyone is all at the doctor's office seeking an assessment and help for their mental health issues, then there's going to be a huge lineup. No one is going to be able to get in, and you know, everyone's looking for those in-person services. But if you have the option of having another way, even if you don't want it yourself, so even if you don't want to access mental health services online yourself, maybe half the people in the lineup do. So then you have, say, a 20-minute wait instead of, you know, an hour wait for the services that you're looking for. So I think it's just a different way to be able to access, where you can get a group of people that are kind of more interested in those services, and that alleviates the wait time and the backlog for the other people as well.
Thank you. Ella, please.
You're welcome.
I just wanted to say it's a nice channel to open up for all kinds of support that people want to get from others. So it's, in my opinion, it's a good way.
Thank you. I thought of follow up to Shlomit's point. I think sometimes talking about loneliness, I think sometimes the thing that does not allow the person to get help is not necessarily access, but internal block that relates to being currently in depression and so on. Sometimes the ability to do something gradual that begins as maybe merely a phone call or using an app, and then gradually improving to the extent that this person might be encouraged to actually interact with a live person or go out and seek help. That is a possibility that we did not have these gradual abilities in the past, and today we might have those. And as time goes by and we learn how to look at these gradual abilities as one spectrum of services that could be offered to different people with adaptability to what they prefer and what they could and so on and need to do, we will have more possibilities rather than, saying that we have to switch one with the other. So it's going to be supporting the system that is fighting to survive with not enough resources rather than replace it with something completely different.
Yeah, and the same goes for stigma as well. I think that's also another reason that people don't seek services, is there's so much stigma out there for seeking mental health services, and especially for different population groups. They face different challenges as well. I know with the male population group, it's really difficult, for people, especially, what background you come from, what country you come from as well, to be able to, have that, be brave and be able to kind of, seek help as well, because society often tells people, to tough it out. So, I mean, there's just, there's so many barriers that way. You're right. Like, access is definitely not the only one. I think we have a long way to go to be able to reduce stigma. We're getting there, I think. There's stigma not only for the person accessing mental health, but there's structural stigma as well in our institutions. So it really is something that we try our best to be able to reduce barriers to, and to be able to open up those channels for people to feel comfortable enough to be able to go seek mental health advice and support.
Yeah. So listening to you, I was thinking, I think I told you that on our first meeting as well. So we also have in Israel something that is called the National Council for Mental Health. It's actually working within the Ministry of Health. We know many of the members there. I don't know that they're having a similar project as large and impressive as the one that you have. I could imagine that parts of what you guys are doing are applicable here. I mean, if you have already looked at different apps, if people are going to use them here, if they're English-based, for instance, then already we have some sort of validation to their, being suitable to some extent. I wouldn't imagine that mental health in Israel has such different standards than it does in Canada, at least clinically speaking and theoretically talking. At the same time, if there are more and more apps in Hebrew, let's say, I wonder, and that's an open question to you, but also maybe to Tamar, who's an expert on regulation and so on. How do we replicate such a project here? Should it be done under the ministry? Do we expect too much from the ministry and it needs to be done by an external body that is similar to your commission, which I don't know exactly if it's a semi-formal commission? Is it a non-profit organization? What would be the best way to promote this? Because people are going to use those apps, whether or not somebody's going to check if they're useful, if they're helpful, or if they're disruptive or causing harm. So maybe your thoughts, Maureen, first, and maybe Tamar, if you have some ideas how we could promote this in Israel, I'd love to hear that as well. Yeah, Maureen.
Yeah, I don't know exactly how you were structured, but I know, in most countries, it has been either through a ministry or sort of the government or an arm's length from the government that has developed items like this. The advantage of having your government involved is also that it may not sit on the shelf at the end, but it might also be part of like an actual plan and policy, and have a bit of teeth, and that people can actually then use the product as well.
Okay, that's useful. So following that, Tamar, your thoughts?
I wanted to ask a small follow-up question, and I'm happy to share thoughts if they're of any value. I was wondering as you were speaking, Maureen, that at least in Hebrew, I don't know many e-health or e-mental health apps because we're a very small market, and usually commercial companies, they might just do something very, better for in the beginning in Hebrew. The rest of it would be in English, which won't be so much accessible to the local patients. And I was wondering if you might have a similar problem in certain cultural groups or in certain languages, or do you feel the commercial companies in Canada give answer to the needs of the population?
Yeah, well, I'm trying to think about any specifics that I can share an example on. But in Canada, we are bilingual, so we have English and French. But we do have a lot of new Canadians coming in who speak a range of different languages as well. So I am curious now if there are some apps that are targeted towards those specific populations. We did develop recently a guide for culturally adapted cognitive behavioral therapy for the South Asian community. And so we did that with the Center for Addiction and Mental Health. And that's not something that is, in an online format in terms of like an app right now, but it is a guide that was specifically developed, for that community. So I think, it is important to be able to target mental health services to the population that you're really looking for. And that may also include adjusting the language to make sure that it is relevant for that population.
Yes, I think one of the challenges of AI coming in is that big data it is working on is, of course, in a certain language and in a certain cultural base. But we all know what we're talking about. So I think, Owen, to your question, I do think that Maureen demonstrates something to inspire and to, we could show people here what is done in Canada. But I am really curious, and I'm going to check now after how many mental health apps are in Hebrew. I would be surprised to find any.
I think, Tamar, it's a matter of also, I'm not sure legally it will be very possible here. I don't know any of those in Israel. It will be hard to get approval for that.
Oh, not as a medical device, just as a support. There are many ways
to
define it.
We are experts on disclaimers, right, as lawyers. So really, the app is only provided for personal enjoyment or whatever. If you need mental health support, please contact a professional. So, these are disclaimers we can find. There are several groups already forming in Israel that look at digital mental health. Some of them we are members on online, and there are many therapists there who are not afraid to, let's say, be open to the possibility of starting to look at what the new technologies could be useful for them when they, just as an example, provide a verbal time of a session and ask for guidance as if it were the supervision that they would have, or for suggestions and so on. So and very interesting insights are already emerging in those discussions. So I do think there's more happening in Israel that we could have thought about. It would be good to see what they have to say and share with us about this. But I agree with you, Tamar, that the market here, because of its size, a lot of people start here, and then after developing the model, they understand that the market is not going to be here. And the only way I think to bridge this would be by some kind of support, governmental support, that would encourage startups to actually invest in the local market. I
think it starts it begins like Microsoft Health. It is has an R&D center in Israel. They had a huge project of annotating data in Hebrew. So there are local initiations, but I'm not sure about mental health, but that's definitely a direction.
You see, we don't like the term market for treating patient.
I know.
Our market, come on, I'm an MD. I'm not.
You're correct.
I'm not looking at this. And if you don't have a good mental system in Israel, let alone to start now something new. We are in such a shortage of you say you can wait instead of half an hour, an hour. In Israel, it's instead of a month, 2 months.
Yeah.
So I mean, it's like.
But maybe
In the
when they wait
I
for a
understand it. It's
psychologist.
wonderful because I used to treat patients, not mental health, remote in remote areas that they have to connect with an Israeli physician if they are stuck in Gambia. Then it works wonderful. I got this, but for mental health, I don't know. And did you see how many people are on her staff?
Yeah, it's 2 years. It's 2 years for children's mental health services here. Yeah.
2 years?
So 2 years if there is a child needing mental health help, and where I'm located, it's a 2-year wait.
Well, I don't know if it's time to start horror stories, but if we talk about, no, but I mean, it's one of the challenges that we have. So for instance, if a child is showing some suicidal talk, but it's not maybe something that people are sure about to what extent they would need to be hospitalized or whatever, then sometimes they would get an appointment for 6 months from now, 4 months from now. And while it's starting to be, they're trying to work on that. I mean, so what do? Do you have to take them to a hospital just to get an extremely fast appointment to start getting treatment? So these are challenges that I'm quite sure Israel is not the only one struggling with, and it's one of the reasons that we need to consider using also other alternatives, but it cannot be the only reason. So I mean, if those alternatives are harmful, then obviously these are non-alternatives. But I think what we're looking at is what you've been doing so diligently, and I think it's wonderful because it is a market, and people create those apps and other things because they seek to gain something from it. Obviously, some would have very bad products, others would have very good products, and because they're not necessarily presented as medical devices or as therapy products, then everybody could have access to it. And while people could access a lot of stuff that are not called medicine and still rely on it, and it could be harmful, it's the duty of the state and responsible professionals to distinguish between the maybe not helpful but not harmful systems and things that could be very harmful, and try to find a way to keep people out of the realm of being hurt by those available apps, just because the system cannot provide them with something faster. So that's why we cannot just leave this vacuum open, not because we need to be so paternalistic, but in a way, I think it's the government's duty to be aware, especially the Ministry of Health, to be aware of this evolving market and not just leave it open to free market. That's because it's medicine related. But my thoughts, though, yeah. Tamar, I think you wanted to say something like 5 minutes ago. If that is correct, then you're willing.
I just wanted to support Yoel's comment about it cannot replace the system's dire needs and budget and normal medical standards, and definitely our standards currently for getting mental health are not good. So we can only suggest it and offer it as a supplemental service, something that could help.
Thank you. Any thoughts? Other people want to say something? So I think at this point, Maureen, I'm happy to hear your concluding remarks, thoughts, maybe feelings about our discussion today.
Yes, it's been really wonderful connecting with you all and hearing a bit about what's going on in other parts of the world as well. I think, if I can offer just a little bit of next steps, if you are interested in, engaging in mental health services and standardization, is starting kind of where you're at right now. So, for us, we years back, we developed even like a 2-pager on how to select mental health acts in Canada. And that was, years ago. And it took, this long for us to get to this point where we have a framework for mental health acts in Canada. We're still not at the point where we have a national accreditation framework. We're hoping to get there someday. So I think, thinking about, where you're at as a country, also thinking about, what is an easy next step? What are items that you can do as a country? If there's anything that we all could help you with, or if there's anything, any frameworks that you see that could be relevant for your context as well, no need to reinvent the wheel, as we were saying. So I think, the focus needs to be on quality e-mental health products and having it as another access point. But, like in-person services, we often hold in-person services up to higher standards than e-mental health, but like in-person services, I think we need to have very quality e-mental health services in order for them to work. Thank you so much.
Thank you very much. Thank you all for participating. And this is our last meeting of this seminar for this semester. Probably we're gonna renew our meetings in a few months. We'll let you all know about that. It's been a pleasure having you, Maureen, and let's keep in touch and hopefully do some good things together. Thank you, everyone. Toda, Amir, toda.
Thank you. Thank you.